I just have just 3 slides as
Okay.
take-home messages.
Good. Okay.
Barrett, if you could. So, yeah, so this is picking up a little bit on what Susan said, but I think at the heart of what we're talking about is really an issue of consent. I think it's very important. You know, you could actually do research without a clinical investigator. There have been crowdsourcing studies like in ALS and the value of lithium. You can even do it without a statistician, but you can't do it without a research participant, people who actually, we talk about patients in general, but there are people who put themselves at risk in the setting of a study, and I think they drive a lot of this. So I think that's very important. I think we lack a lot of data on this, how research participants view data sharing, how well educated they are about it, and I think there's a lot of ground to make up on that. In the area of Huntington's disease, a genetic disease, hereditary disease, we've actually accrued some data in terms of opting in and opting out on what will be shared. It's very interesting that our experience is 97 to 98% of people opt in for data sharing, mindful of the fact that and this was before the Genetic Information Non-Discrimination Act, mindful of the fact that they can encounter an incredible amount of discrimination as a result of data sharing and identification. Having said that, I think genetic data and hereditary data, family history data, is a real big, important issue that has not been solved. I think they are identifiers. There's no question in my mind. And I think they are also so enriching as far as clinical trials in terms of the information that that's an issue that needs to be solved. I already gave you that example. The research may not benefit me directly, but may benefit others. I think research participants in particular, and patients and families in general, have a big stake in data sharing because they want the information disseminated and used and as much as possible. And as I said, you know, imagine if a potential participant stipulated that I'll participate in the trial only if you would share the data. And as I said, the consent form is not a contract to do that, but I think there's a lot of basis for saying that. I just want to mention, I talked about the cost of data sharing. I think we lack prospective information on this. I think it's important to gather this. These are the categories that we used in terms of looking at the Academies study, the broad costs of infrastructure and administration. There's some detail there. Standardization, human resources, which we think is the biggest category, and opportunity costs. And by the way, this will require a lot of work in terms of adapting this. Much of this work goes into any clinical trial, so they're kind of like there are marginal costs involved. But I take Janet Whitty's point is the cost of actually sharing data and explaining to others, there's a big additional cost, and it's much greater if it's done as an afterthought rather than prospectively during a study. Just one final take-home thought in terms of language. I never use the word informed consent because I don't know whether my research participant is informed. I know I got through the consent process. So I think we lack, you know, we use this word a lot and we tie it together, informed consent, as if whatever that process is, they are informed. There's actually been interesting paper reported in New England Journal of Medicine about a month ago in terms of how informed research participants actually are. And we kind of tie this together, compassionate care, we link together honest broker, trusted intermediary, and also now responsible data sharing. Now, I just want to point out these are all aspirational things. We hope this will come about, but I think we should be careful in terms of not kind of prejudging that these go together. I heard another one today, protected health information, PHI. Of course, we can't guarantee that it's protected, but we still call it protected health information. So there's a lot of ironies in terms of the language that we use. Just some final thoughts. I threw this out, but I think thinking about extending the period of exclusivity based on data sharing requires some more imaginative thinking. I talked to Michael Rosenblatt about that a little bit afterwards. He said the generic people would be all upset, you know, if you gave an extra year to do that. On the other hand, if we're weighing the public good about this, and there is really a value in data sharing, maybe, you know, that's one way of resourcing it, and I think something to consider One, and I also mentioned the fact that I think we need more empirical data about data sharing. I kind of said tongue-in-cheek that we have a journal of data sharing, but I think something like that may actually be helpful. It was interesting to hear that PLOS One's going to publish replicated data analyses, but I think we need a venue for doing that. Just one last thing that has not been discussed at all during this, and I know FDA is one of the sponsors for this particular program, but I think it'd be interesting to ask the regulators their thought. I think there's a lot of cognitive dissonance within the community of regulators about data sharing. I think there's a lot of altruistic feeling that this would be good, but I think there's also a sense, most people at the FDA and the division spend almost all their time analyzing data in terms of clinical reports, and I think there's a lot of hesitation that they might have in terms of being second-guessed in terms of data sharing. Now, that might turn out to be okay, but I just want to bring that up as something that hasn't been discussed and probably bears some attention.